Hey guys, do you still enjoy the chest radiographs? Okay, let's enjoy the chest radiographs with Dr. Y. Session 21. Today's topic will be about lung metastasis. I'm Dr. Y, chest radiologist, medical professor in South Korea. Before entering the session 21, let's review the session 20, other primary lung tumors. What do you remember with the name hamartoma? Yes, most common. Yes, fat tissue, and sometimes stippled and popcorn calcification. Great. B. Salivary gland tumor such as adenoid cystic carcinoma and mucoepidermoid carcinoma. Yes. Large airway tumor. Not so characteristic. Okay. C. Carcinoid. Typical is better for the patient than the atypical carcinoid. Yes, strong enhancement on the contrast-enhanced CT and no such uptake on the PET-CT. Yes, great. And sclerosing pneumocytoma and very rare, the primary lymphoma. Other names are maltoma and baltoma. Great. Let's start session 21 from the definition of lung metastasis. Yes, definition is cancer that has spread from the original or primary tumor to the lung. Do you happen to know why the lung is the most common site of metastasis? Then liver, then bone, then kidney, then muscle? Yes, because lung pulmonary system receives every single drop of blood from the systemic circulation that may contain cancer cells. So, lung is the only counterpart of the whole body, the systemic circulation. So, systemic circulation against pulmonary circulation. That's why lung is the most common site for metastasis. Radiologic findings of lung metastasis. Let's get some information about the mechanisms and a glimpse of radiologic findings of the metastasis. A. Hematogenous spread. Multiple peripherally located round variable-sized nodules. This is the most common finding from hematogenous metastasis. B. Lymphangitic carcinomatosis. Diffuse thickening of interstitium. C. Aerogenous spread. Persistent centrilobular nodules and twin bud patterns. Not common findings of lung metastasis. For example, cavitation, calcifications, hemorrhage around the nodules, pneumothorax, airspace pattern, tumor embolism, and bronchial metastasis, single solitary mass. Hematogenous spread. This is the most common findings. Cancer cells go through the arterial system, pulmonary arterial system, latching within small pulmonary artery or pulmonary arteriole. In most instances, newly formed tumor extends into the surrounding lung parenchyma, forming a nodule. They are usually bilateral and randomly distributed more preferentially in outer third and lower lung zones due to gravity, the blood flow. Tumor embolism. It is a special form of hematogenous spread. Occasionally, tumor grows only in the vessel lumen and wall without extension into extravascular tissue. Renal cell carcinoma, hepatocellular carcinoma, breast cancer, stomach cancer, and prostate cancers are examples. We sometimes call them vascular tree-in-bud because it is not the famous airway tree-in-bud of tuberculosis, but it's in the pulmonary arterial tree-in-bud, so we call vascular tree-in-bud. B. Lymphatic spread, lymphangitic carcinomatosis. A. Most often indirect. First, hematogenous spread to pulmonary artery or pulmonary arteriole, and subsequently invade into interstitial space and lymphatics. Less commonly, backward invasion from mediastinal and hilar lymph node metastasis. Lung cancer and breast cancers are famous. Often we find hematogenous metastasis and lymphogenous metastasis combined form. In that case, we may call hemolymphogenous metastasis. Lymphatic spread too. Pathologically, from slight accentuation of septa, interlobular septa, and peribronchovascular connective tissue to marked thickening of these structures. Microscopically, neoplastic cells can be present within lymphatic spaces or in adjacent peribronchovascular and interlobular interstitial tissue. Edema and desmoplastic reaction may contribute to this interstitial thickening. C. Aerogenous spread. Let's presume with lung adenocarcinoma as a primary site, and following expressions are postulated, and many people, including me, agreed with this postulation, but we may need some more proof. Let's go. A. Detachment of cancer cells from the primary sites, alveolar septa. And these cancer cells spread through the airways. And these cancer cells reattach and grow in the other alveolar septa. Postulated and still need some more proof. That is the mechanism of aerogenous spread. Lung adenocarcinoma is famous, and sometimes carcinoid is also. And one more thing, endobronchial metastasis is different mechanism. It is a different one. It is actually a hematogenous spread, such as renal cell carcinoma and melanoma, and some other cancer cells too. Radiology of metastatic lung nodules. A. Multiple nodules, most numerous in the base, lower lung zone, reflecting blood flow. B. Ill-defined or well-defined nodules. C. The size of the nodules are very visible, micronodules to masses. D. Usually of a varying size. E. Sometimes almost equal, suggesting a single shower of tumor emboli. Miliary metastasis often mimics miliary tuberculosis because they are almost uniform micronodules. G. Single metastasis, renal cell carcinoma, testicle tumor, breast cancer, rectozygomoid osteosarcoma, and melanoma are famous. H. We need differential diagnosis with septic lung emboli. Sometimes they are very similar, sometimes very clear. CAT scan findings of lymphatic spread, septal lines and thickening of bronchovascular markings simulating interstitial edema, prominent core structures, linear accentuation often associated with nodular component resulting in reticular nodular pattern, central lymph node enlargement, central such as hilar or mediastinal, and pleural effusion. Let's enjoy the two hematogenous metastasis cases. First, left one. Many, numerous, bilateral, round, variable-sized nodules, more bigger, more dominant on the lower lung zone, colon cancer metastasis. And how about this one? Not many, several, relatively uniform-sized lung nodules. This is also from colon cancer. Let's move to another hematogenous metastasis. Bilateral, symmetric, many, numerous, round, solid nodules. Yes, hematogenous metastasis. This is the non-contrast axial CT of lower lung zone. We see many solid nodules and also cavitated nodules, and some calcifications in the nodules. Calcifications. Cavitation, calcification. This is from rectal cancer. How about this middle-aged woman? There are many bilateral, round, variable-sized nodules, or hematogenous metastasis. How about this one? Large mass in left lower lobe. Yes, large mass in contrast-enhanced axial CT. Large mass, hematogenous metastasis. Actually, this is from renal cell carcinoma. Sometimes this kind of large mass misleads us to recognize this one as primary tumor. And sometimes we used to name this kind of large metastasis as cannonball metastasis. How about this chest radiograph? Yes, his heart is big, cardiomegaly, and there are several nodules, variable-sized nodules. Do we see calcifications here, here, and here? Yes. This is coronal non-contrast CT. We see calcifications in the middle of the metastatic nodules. This is one of the hematogenous metastasis showing calcifications from chondrosarcoma. How about this radiograph? He has a chemoport here. Sure, he is a cancer patient receiving chemotherapy. Let's look at the left main bronchus. From here, stop to here, blind poach. You see? Yes, it is blocked in the middle of the left main bronchus. Let's look at the CAT scan. This is contrast-enhanced coronal imaging of CAT scan. Yes, in the middle of the left main bronchus, we see a mass endobronchial metastasis from colon cancer. What do we see with this patient, this old woman's chest radiograph? Yes, uniform micronodules. Micronodules means usually less than 3 millimeter. Uniform micronodules bilateral. And how about this? This is actually tumor. In this thin section, long window setting chest CT, we see micronodules almost uniform in size, less than 3 millimeter. Yes, in the lung parenchyma, subpleural, in the fissural. So we call this as random distribution, a typical finding of hematogenous metastasis. Sometimes we see this kind of findings in the miliary tuberculosis or in the miliary metastasis. She has adenocarcinoma here in left lower lobe. This is the primary lung cancer, and she has shown us miliary metastasis, a hematogenous metastasis. What about this chest radiograph? Yes, supine film. Many, innumerable micronodules and small nodules, bigger on the lower lung zone and bilateral pleural effusion, hematogenous metastasis. This is axial contrast enhanced CT of this patient. Hematogenous metastasis everywhere, small variable-sized round nodules bilateral. Hematogenous metastasis usually does not come alone. She, in many cases, has companies. Lung metastasis, pleural metastasis, lymph node metastasis. So, she has lung, pleural, and lymph node metastasis with bilateral pleural effusion, probably malignant effusion, from uterine cervix cancer. Let's move on. This old man does not look healthy. Let's look into the red square. What do we see? Something linear, something hazy in the periphery. Let's look at the enlarged, magnified one. Yes. Variable densities, linear densities, nodule-like densities, nodules, beadings. Anyway, there are many densities here in the periphery. Normally, we don't have densities in the peripheral lung zone. Axial lung window setting CT. What do we see? Let's look at the normal area. Probably this area is normal. No remarkable density in the peripheral lung zone. This left lower lobe looks also normal. There is no remarkable densities here, no airway densities, only small minimal pulmonary artery or venule densities visible. That's normal. But we have many densities here. The shape is branching pattern of pulmonary artery, arteriole. Yes, some tiny nodules around it, beading, just like beading appearance. All are same. Just somewhat looks like tree in bud of tuberculosis. We call this one vascular tree in bud. Actually, these are pulmonary arteries, pulmonary arteriole filled with cancer cells. This is called tumor emboli from colon cancer. Let's look at these magnified images. these densities shouldn't be here. That's abnormal. And this density is a branching pattern. This means airway or arterioles and beating nodules are cancer cells in the pulmonary arteriole. Yes, tumor emboli. All are same. This area 2, this area 2, this area 2, all are same. Let's move to lymphangitic carcinomatosis. Right hilum this is lung cancer. And let's look at these two yellow square. Yellow square. Let's move to magnified one. This area should be not crowded like this, as we have seen in the previous slide. There are many net web-like structures, linear densities, square densities, and if we see more closely, there are nodules. So we call this as reticular nodular pattern, reticular nodular density. How about this one, lower portion? This is bronchus lumen. The black one is lumen and wall is very thick. This is bronchus. The wall is very thick. The bronchial wall shouldn't be thick like this and should be regular. This is irregular. This means bronchovascular bundle is not normal, abnormal. Please compare with the left lung. Left lung is normal. This density is normal. Lung shouldn't be like this. Pleural effusion. Left side lung is normal. Please compare what's wrong with the left side and right side. What's the difference? Let's look these two CT images. Left side is axial thin section lung setting. Right side is coronal thin section lung setting. Yes, this is the famous finding of lymphangitic carcinomatosis. Let's look closely and compare with the normal left side. First, we see the pleural effusion here. Septal thickening. Always compare with the normal left lung. Septal thickening, arcade formation. And in the central portion, prominent central core structure. Not here on the left side. No septal thickening here. No pleural effusion. Septal thickening. Prominent core structure. Yes, this is the lymphangitic metastasis findings of CT. How about coronal image? Yes, we see nodules, prominent core, septal thickening. Left side bronchus wall is not thick, uniform in size, but right side is thick, irregular. Recognizable. Yes, this is the bronchovascular bundle thickening, septal thickening. Yes, all represents lymphangitic metastasis. What about this frontal radiograph? Please look at the distal trachea on the left side. You got it? Right distal side looks okay, but left distal side is not looking okay. Yes, bulging mass here. What is this? Distal tracheal tumor. How about this case? This one is mass, lung cancer. And what about these areas with pleural effusion, interlobular septal thickening, Gillespie line, and we see many small tiny nodular density. So we describe this as reticular nodular pattern. Reticular only is not so miserable. But when we say reticular nodular, nodular means malignancy. So reticular nodular is not a good pattern. Let's compare with the left side. Left side is relatively normal, not absolutely normal. Let's look at the CT. Actual image of thin section. Right lower lung cancer, bronchovascular bundle thickening of lymphangitic metastasis. Look at the normal left side. This is normal. And how about the lower portion? Yes, this is the mass, including lymph node with bronchovascular bundle is very thickened. Left side is normal. This is normal bronchus size and clean lung zone. Also have some metastatic lesions here too. And there are many micronodules, prominent core, and pleural tiny micronodules, thickened major fissure, thickened interlobular septum. This is lymphangitic metastasis findings. Let's move to aerogenous metastasis. What do we see? Retrocardiac, large consolidation with many ill-defined nodules. Ill-defined nodules with air bronchogram. In this contrasting actual CT, we see left lower lobe consolidation with many nodules. This is proven as lung adenocarcinoma of left lower lobe. How about this axial thin section CT of lung window setting? Yes, left lower lobe superior segment portion. Many ill-defined nodules with some feature of twin bird pattern. Twin bird pattern means in the airway spread pattern. After 3 weeks, we find more ill-defined nodules making consolidation and more ill-defined nodules, more twin bird patterns. So it means it has grown up. Thank you so much for your effort. We just finished long hours about learning lung metastasis. Let's move to the medical exam cases. Do we see innumerable cystic lesions here associated with tuberous sclerosis? Yes, lymphangial leiomyomatosis. Medical exam case number 4. What is this line? Yes, this is azygos fissure made of 4 layers of pleura. This is teardrop of azygos vein, and actually this lobe is azygos lobe. Where have all the handsome Marlboro men gone? Do you know? Yes, actually COPD and lung cancers. Many of these handsome guys have died because of COPD and lung cancer. Medical exam case number 5. Diagnosis, please. What are the 2 masses in both upper lobe on the CT coronal image? Medical exam case number 6. This is HIV positive patient. Diagnosis, please. Axial thin section lung window CAT scan. We see right pleural effusion, diffuse bilateral ground glass opacity, and many small cystic lesions and lymph node enlargement. Diagnosis, please. Like, subscribe will be a big support to me. Thank you very much and have a good day.